Welcome for our webinar. It's my pleasure to open this section today. My name is Simone Kodlulovich. I'm chair of the Professional Relations Committee who is organizing this webinar. I will be moderating this session with my colleague Stephanie Parker, who will now introduce our speaker, Professor Samei. Please, Stephanie.
Hello, everyone. My name is Stephanie Parker, and I'm thrilled to be here co-moderating this session. I'd like to introduce Dr. Ehsan Samei. He is the Reed and Martha Rice Distinguished Professor at Duke University, and he directs the NIH-sponsored Center for Virtual Imaging Trials and co-directs the FDA-sponsored Triangle Center of Excellence in Regulatory Science and Innovation. His expertise includes clinical physics, the smart use of AI, and quantitative imaging. His passion is to position in silico methods to generate and accelerate patient-centered care in design and practice. He has authored over 370 referee papers and is a fellow of 5 professional societies and the recipient of the 2022 Marie Curie Award by the IOMP. Without any further ado, I'd like to welcome Dr. Ehsan Samei, and we're thrilled to have everyone here for this webinar.
Thank you so much, Simone. Thank you so much, Stephanie. Thank you for the warm welcome. Thank you, Magdalena, for arranging this. It's great to be with all of you. Thank you for joining this morning, this afternoon, this evening, wherever you might be located. Let me share my screen. And I trust that you can see my screen okay?
Yes.
Yes, perfect.
Lovely. Great. Should never take things as granted. Not always things work. So I am really excited to tell you about where my head is these days in terms of why physics is such a crucial component, is a crucial contributor to medicine today and to the medicine of the future. I'm directly focusing on especially the next generation of medical physicists. That includes myself. I'd like all of us to think about energizing and re-envisioning our profession as we practice it, because that's a good way of staying fresh. So this is just general outline of my talk. I'll talk about the what of medical physics, why medical physics, and spend most of my time about what I think the frontiers of medical physics are and what direction we should be heading. So what of medical physics? Of course, you're all familiar with these sceneries from Marie Curie and from Röntgen. We know that medical physics, you all know about the practice of physics in medicine. It has shaped medicine as we know it today. It was an interjection into medicine through Röntgen, through discovery of X-rays and the birth of radiology, and became the foundational discipline and technology behind radiology and radiation oncology. It has ordained optimum use of radiative energy to extract care-relevant information. That text in blue essentially is the shortest definition of medical imaging. Ordaining optimum use of radiative energy to extract care-relevant information. And also in the therapy space, designing, curating, and directing radiation for individualized therapy. That has been the mainstay of the field of medical physics as we practice it today. But at the same time, medical physics and the injection of physics into medicine has shaped our culture and our society. X-ray has overhauled our concept of privacy and modesty in the Victorian era at the end of the last 2 centuries ago, I would say. Curie has remodeled the role of women in science and in service of society. And radioactivity, even though we cringe every time we hear about it, has energized the magic and reach of science. So in the service of diagnostic medicine, of course, the definition is that we ordain optimum use of radiative energy to extract care-relevant information, use sophisticated equipment to get sophisticated images at the levels that we have never been able to do in the past. And in the therapy space, we have put that into the service of therapeutic medicine, designing, directing, and customizing radiation for individualized therapy. We use similar technology, of course, purposed for radiation therapy, and then we orchestrate and personalize the therapeutic regimen. We talk to our colleagues along the process, but eventually initiate the therapeutic regimen. So, but at the end of the day, you should ask yourself, why are we doing what we are doing? Fundamentally, why physics has a role in medicine. And I would like to take a few steps back and ask the question what medicine is all about and how physics can inform it. So medicine is about discerning, intervening in the health state of the patient with sufficient accuracy, precision, and safety for definitive clinical outcome. Healthcare is about the patient, not the particularities of techniques or technologies that we use, even though they are valued to the extent that they benefit the patient. Is that possible? It is possible, but it's difficult because, number one, clinical practice, as we actually put those technologies into the healthcare environment, tend to be applied in a very heterogeneous and variable way. The clinical practice is highly heterogeneous and variable. There is an ever-expanding range of varying technologies. There are varying technical parameters that ordain the use of those technologies. There are varying patients, of course, varying human operators and interests, and that creates variability in the quality of care. That's why when we get sick, we shop around to the best practice, best doctor, best intervention, because we don't get the same thing everywhere, right? And this affects the quality of care. This is a study that we did a few years ago and look at the facilities that are accredited by the American College of Radiology in the US. And we look at 804 different protocols. And we look at the measure of quality that we could ascertain from those images that were submitted for the accreditation process. On the other side of the actual practice, there was almost a factor of 3 difference in the quality of the images. All of these facilities were considered adequately accredited. They were high quality facilities, but still there is a significant variation from one facility to another. The question is, we should ask ourselves, the second question is that variability bad? Well, this variability is evidence that can harm patients. Most people will experience at least one diagnostic error in their lifetime. This is from a report from National Academy of Medicine 10 years ago now. They stated that 10% of the patient deaths are due to diagnostic error. Not all of that, of course, due to medical imaging, but medical imaging is a big part of the diagnostic workup for a patient. Radiation therapy, of course, needs to have its own error management. That's why we use a number of processes in place in order to minimize the likelihood of error and variability that might potentially harm patients. So variability in the quality of care harms patients. So we need to manage that space. At the same time, there are changes afoot. Focus on evidence-based medicine, practice informed by science, precision medicine, personalization of care in quantitative terms, comparative effectiveness, meaningful use, enhanced focus on actual utility as opposed to presumed utility, and value-based medicine, scrutiny on the stewardship, on the safety, quality, consistency, efficiency, and ethics of our operation. So you can think about the need that we have in medicine are as follows, at least in the case of radiation use. We have heterogeneous and variable clinical practice. We need to ensure consistent quality and safety to address that heterogeneity and anchor that to actually the clinical purpose of the imaging or therapeutic regimens. We have variably informed science in practice. Not everybody engages the science in their practice as others. So there should be a focus on the evidence-based medicine. There is a focus now, the need on quantitation and personalization of care. There is a need for precision medicine. There is a focus in medicine on outcome-informed medicine, not just what we put into the patient, but what the actual outcome of our care is. That put a scrutiny and the need and the goal for accountable medicine, for meaningful medicine, for comparative effective use. Not just we put a new machine in there and therefore everything would be great. The question is that after we put the machine in there, how the care of the individual actually gets better. And focus on stewardship, efficiency, safety, and quality. So there is a focus on value-based medicine. So the stuff on the left are the stuff that we need to be addressing, and therefore the goals on the right are defined. I would argue that medical physics has a role on every single item that you see on the right side of this slide. So we need to have this drive towards high quality care. We need patient-centered design and optimization of physics-based science in medicine. And that's essentially medical physics. And in order to do that, really to get to that point, patient-oriented design and optimization of physics-based science in medicine, we need to transform the field of medical physics. That's what the concept that we have initiated in the US a few years ago, and it's still going on, the concept of medical physics 3.0. And you can learn more about this if you go Google just medical physics 3.0 and find it on the web. And there is a whole web page with a lot of resources. You can check that out. So you can think about medical physics in some sort of a progression from a medical physics 1.0 practice to medical physics 3.0 practice. In the 1.0, we are focused primarily on equipment. In the 3.0, we focus on the actual operation of that equipment and practice that is anchored to that equipment. We are moving from specification and compliance to actual performance in clinical performance, going from quality check to consistent care, going from presumption to actual utility, going from planned care to actual delivered care, going from machine-centered care to patient-centered care, going from physics in medicine to physics for medicine. This is distinctly different. We are not just physicists that happen to be in medicine. We are in medicine to be for medicine. And of course, physics of medicine. That is also another component of our enterprise. So you can think about medical physics 3.0 in one nutshell. If you ask me, so how you define 3.0, this is my shortest definition of it. It's about fostering human health through innovation and precision of physics. Those things come from physics, aimed towards patient-centered care. We are physicists that practice physics for the direct benefit of the patient. We can do it either immediate benefit to the patient, we call that clinical physics, or eventual benefit to the patient, we call that scholarly or research physics. You see, clinical and scholarly approach toward physics are essentially the same way. They just don't have different time horizon. That's all it is. It's about physics for patient. And I think there is a lot ahead. Medical physics has done a significant amount of work, but all of that is summarizes in that small piece of that pie. I think there is a lot ahead for us. And the question is that what limits are reached? So I'm going to spend the rest of my time to talk about how do we expand our pie, so to speak. So, and I like to think about three areas that I would like to focus on. How do we advance this medical physics to this transformative state that I would love to talk to you about? We can call it medical physics 3.0. You can use your own label, whatever, it doesn't matter. Naming doesn't matter. The point is that what we are after. I think in order to get there, we need to have three things, in my opinion: personal ownership, professional ownership, and communal ownership. I'm going to talk to each one of them individually. Let's talk about personal ownership first. So who we are, I think we should ask the question, who we are or we ought to be. So I think, first of all, in this space, as medical physicists, we need to be owners. We need to be scientists, we need to be service-minders, and we need to be multi-visionaries. Let me talk about each one of them individually. What do I mean by being owners? That means we are professionals with confidence that optimum care needs purposeful contribution of medical physicists. You need to believe in that. If you don't believe in that, well, there is not very much we can do. And you can ask yourself, why would that be? Because I argue that our unique combined qualities can and should meet medicine's greatest needs. Combined qualities, I'm talking about the physical orientation to the world, towards the world, and care orientation towards the world. And what are the medicine's greatest needs? I already talked to you about innovation, evidence, quantification, precision, technological solution of practice, and patient relevance. All of those words has direct implications, direct relevance, direct affinity for the field of medical physics. And we need to be professionals who practice curiosity. You ask the question, I wonder, and fill the blank. You need to practice imagination. What if, and you imagine what might be there that is not there right now. And commitment. So what? Why are we doing what we're doing? And in doing so, we also concurrently need to practice humility. And I think that's a significant human problem. We get tripped by our own ego. Uh, we have this propensity to have this illusion of self-sufficiency, that me, myself, I can rewrite the field of medical physics. I can't. None of us can. In fact, medical physics came about as a communal enterprise of all of us together. So we need to be able to work together with humility. So who we are and we ought to be, we are owners. We are also scientists. Scientists, both in discovery, that's research, and application, that's clinical practice. We are scientists nonetheless. We are scholars. We are focusing on evidence, methodical pursuits, critical thinking, curiosity, and that applies across all practices of medical physics. We are quantitators, if such a word exists. We are numerically oriented. We are measurement oriented. Because when we measure things, we can approach them scientifically. We are innovators. Innovation by itself is an agency, is an agent of advancement. That's why innovation is so important. Innovation for better understanding, better practice solutions, better care delivery, better technological solution, better education, better regulations. Innovation is necessary for us to practice as scientists. So when I say scientists, those three things comes to my mind: scholarship, quantitation, and innovation. We are also, as medical physicists, are or ought to be service minders. What do I mean? We are professionals who care, having a customer mindset towards ultimate clinical use. We are caring to personalize the extent of the work to individual care, to optimize extending our work to maximize the benefit, and apply that consistently, managing variability across diverse technologies and patient factors. See, some of those elements that I mentioned earlier about what medicine needs, you see those attributes, those needs reflected in who we are as persons practicing our physics in medicine. And the fourth one is that we are multi-visionaries. What does that mean? That means we are professionals who practice science in context, not just isolated, in context, through having a dual vision. We both are able to have a myopic vision, looking at a particular problem in a very focused way, but also see how that solution that we might come up have a systemic, broader reflection in the overall care of the facility, of the patient, or whatever. This myopic and systemic vision is something that I have seen uniquely in the profession of medical physics, and I have seen that not as much in other professional practices of medicine. And also we have dual callings. We are medical physicists. That means we are physicists, we are scholars, but we are medical physicists, we are healthcare providers, and we have them both. And this, in fact, in some ways, this duality elements that I'm bringing up is one of the assets and also one of the liabilities of being a medical physicist, because it's hard to be two things at the same time. Okay. Now let's switch now, getting less personal. Let's talk about the field in general. What do we need to do in terms of professional ownership? What discipline is or ought to be? The previous section, I talked about what we individually are or ought to be. Now I'm talking about the discipline at large. You can think about that the foundation of the discipline is eventual contribution of physics to medicine. In that space, we are talking about research and development, right? What do we do in that space? We use the science of physics, mathematics, computational science, engineering, whatever it takes and we incorporate that science into our amazing brains, and we develop innovative technologies and applications in the research domain. So we can apply those innovative technologies and applications to patients. You can think of this, you are in the space of creating technology for practice. So the question that you might ask yourself, okay, are we doing this? Well, what are the frontiers in the research and development, if that is where your head is? Let me highlight a few things that I feel like we need to advance, frontiers. Number one, what are the big challenges in medicine? We need to align with medicine at large and medical physics beyond radiation medicine. If you ask 100 doctors, what is the main challenge that you have in medicine today? I wonder to how many of those challenges medical physics can speak to. We do need to figure that out, and we need to be present in that space. Where there is a medical challenge, medical physics needs to be present. The second area is that the hardware advancement of our space, new sources of signal, I would characterize. We should ask ourselves the question, what is that we still cannot see or we cannot impart? Seeing, I'm echoing medical imaging. What is it? What are the sources of signal that we cannot see, we cannot visualize, we cannot pull out, we cannot extract? And also, what are the sources of signals that we are not able to impart? By impart, I am directly speaking to therapy. That's where we impart signal as opposed to extract signal. In the software space, we need to focus on new understanding and use of that signal of ours, owning the foundation of data. I think one of the foundational attributes that medical physicists have is that we understand data. There is a lot of work in the space of AI, but many AI scientists they are data processors. They don't care deeply about where the data comes from, what the data means. And that's one of the limitations of AI. So this is a space that we can actually own the data, the foundation of data, fostering AI analytics and other form of analytics that are physics-based because we know the foundation of them, but are data informed. So taking advantage of the data as well, and thus explainable and generalizable. This question of explainability and generalizability of AI that everybody talks about it and nobody seems to have any really solution around it, is that we don't deep down understand what the data is and where it's coming from. And that's a space we can expand. And the fourth one is advancing the challenge of experimentation in medicine. You probably have seen some of the material that is coming from the US in the last year of NAMs, new alternative methods, and you might want to Google NAMs, and you will find quite a few material out there. What is NAM stand for? Is new alternative methods, and there are different alternative methods: in vitro, in vivo, and in silico methods, as more efficient alternatives to human-animal trials. So see, we have a problem of experimentation in medicine. We cannot do experiments in medicine because experimentation in medicine is highly constrained by ethics, because we cannot practice on patients, by epistemology, because we never know what's actually going on until we put this stuff into practice, lack of certainty and truth, and by resources. Any clinical trial that any of us might want to take takes time and money, right? So we have a fundamental problem in this space. So you can think about that. If you are after understanding clinical quality, you never can get your hands on the right side of the spectrum. So closest to that is that you can do in vivo human trials, but they are very extensive, takes a lot of money, takes a lot of time. You can do animal trials right in the middle of this spectrum, but that is also expensive. Or you can do go all the way to the left side of these things and do mechanistic models. All things being equal, you already know if the noise is higher in an image, image quality is poorer. Is the MAS is higher in the X-ray imaging system, that means the dose is higher. These are what you call mechanistic models, if you will. So, but you see, you can use mechanistic model all the way on the left side of the spectrum, You can use in vitro trials that you can think about in our space using phantoms. But as you go to the left side of this spectrum, you are inferential. You're farther removed from clinical reality that is on the right side of the spectrum. Alternative to this would be in silico models. So for example, you can have in silico a computational model of the patient or a computational model of the animal and try the experimentation that way. So again, in this spectrum of evidence generation, you can think about the stuff on the right tend to be highly definitive, but very impractical to do. And stuff on the left are very practical, but very inferential. So medical physics can practice in this domain, can relate these different ways of experimentation, if you will. And that's one of the things that I have been doing. Stephanie mentioned that I run this Center for Virtual Imaging Trials at Duke University. I'm the lead of the center. We have a number of co-leads on this initiative. It's a national center in the US to develop and provide a virtual platform, a computational platform, to assess the clinical performance of medical imaging systems from design to use, all the way from design to the use. We are focusing on imaging, but actually we have a number of therapeutic applications as well. If you want to learn about the center, just check our website, cvit.duke.edu. We are resourcing and enabling virtual trials, informed by 2 advisory boards, and we have 5 cores and 26 collaborating projects from academia, industry, government, and societies, nationally and internationally. And so what is virtual clinical trials, you might ask the question? Is conducting a clinical or imaging trials in silico. So in the real trial, you have real patients with real intervention, with real physician interpretation. In the virtual trial, you have a computational alternative to those attributes. You can think about this as medicine meets Matrix. If you have seen that movie Matrix, if you have not done it, I would highly recommend it. You can think about what is the vision? What do you do with this in silico modeling of the patients and so on? Well, one is what I already mentioned, digital trials. So you find alternative to clinical trial, making trials better. Instead of doing real trial, you do computational trials. You can also make products better, prototyping and design optimization of a system. If you have a new system, AI system, hardware system, software system, new way of managing motion, respiratory motion in radiation therapy, whatever that is, you can prototype it digitally and see how it works, making products better before you actually go through the designing, actually making the actual device. Or what I would like to be doing eventually is the most exciting one is digitizing each one of us, optimizing and personalizing care, creating digital twins of each one of us. In that process, we would be able to make care actually better for individuals. So in that process, in our lab here at Duke University, we have a model called XCAT model. We have virtual patients. They have all the organ system representing these patients. They're dynamic patients. They move, beating heart, and so on. And not only we have a whole family of these. There are upwards of 3,500 models now developed, including pregnant patients, females, male, pediatrics, and so on. We model organs inside these patients, details of the vasculature, airways, and so on. I'm going to go through this very quickly. This is an example of, for example, what you can model. You can give these individuals, tell them to take a deep breath or take a shallow breath. And in this case, we model a patient. I'm just showing you a slice of the patient. It's not a CT, looks like a CT, but it's real, actual model, digital model. You see reasonably anthropomorphic. On the left lung, you see 6 lesions. If you focus on that. On the right lung, you see the emphysema modeled as well. We also model other attributes, dynamic attributes inside the body, including, for example, GI tracts. We can actually keep track of the movements inside the body. We have models of the heart. These are dynamic models of the heart. And we are able to represent not only one heart, but the multiplicity of hearts. So we can do cardiac imaging and cardiac care processes. We model the pharmacokinetics of content, in this case, contrast agents. As you see on the right side, how the contrast pool moves from one organ to another organ using a differential equation. We model abnormal tissues. We have modeled cardiac plaques, COPD, COVID, fractures. We model, of course, tumors, tumor variability, and growth. These tumors can be embedded as needed in different tissues. So you can essentially create as realistic of a possible model of the patient. And then we can now image this patient or put them into some sort of therapeutic regimen. This is a simulation now of the imaging process. And that's also significantly physics-based. You see, you can get a ground truth of the real patient. This is a patient, cross-section of a patient, virtual patient again. Who's embedded with 4 lesions in the lungs. I'm just magnifying one of them. And you see, after the imaging process, that ground truth of the tumor of the patient is now represented in the imaging domain in CT. And here lies the essence of imaging, to try to create a visualization of reality, but never a perfect visualization of reality, an approximate visualization of reality. So we could ask ourselves the question, how best I can image the patient to deliver the maximum clinical outcome. As I mentioned, this is a rather deep space, how to do the modeling. This is only the modeling that I'm showing you for CT scans. We're also doing this in some other modalities as well. To be able to model in the same way that we're realistically modeling the patient, if you want to model realistically an imaging device or a therapeutic device, you need to model every single precise attributes of the physics that takes place inside that technology. For this CT case, you need to model, of course, the geometry exactly. You need to model the source of the energy, the Hill effects, the tube-current modulations, the dual source, the shape of the focal spot, the bubble of the focal spot. You need to model the detector, how the detector processes the signal efficiency, the noise efficiency, the energy efficiency, the pulse pileup, and all that. And then reconstruction process. How do you account for beam hardening? How do you account for a scatter? So if you can replicate that exactly, then you essentially have a digital twin of the scanner now. And you can put a digital twin of the patient into a digital twin of the scanner, and then pass it to a digital twin of the physician, and then you have the entire care process digitized and modeled. So you might ask the question, what are the applications of this? What do you do with this? So one of the applications would be, well, let's focus on female health, for example. We have models of the breast. So we can do multi-model imaging of the breast. On the center, I am showing you different modalities, ultrasound and CT and MR. So we can essentially image the breast of the same patient without actually imaging the patient. This is a virtual space, right? And you see how simulated ones are realistically looking compared to the real ones on the left. We are engaging right now in a project on osteoporosis because that's a particular issues with older female individuals. And we would like to see if we can make the quantification of osteoporosis and follow-up of osteoporosis more robust using our virtual domain, because we can do trials. We also have done work in astronaut dosimetry. 2 female of our models made into physical form and flown around the moon as a part of the Artemis mission. And we embedded these models with multiple dosimeters, so we could actually measure and predict the amount of female dose to astronauts for a potential trip to Mars. And why we used only 2 models, there were 2 models, one with grid, one with apron, radiation apron, shielding to minimize the cosmic radiation, and one without. And we did that in the context of females because, as you already probably know, female individuals tend to be more radiosensitive than males. Another application, we can do individualized organ dosimetry. These are three pediatric patients that have undergone chest CT and abdominal CT exam, and you see the pattern of dose deposition inside the bodies. You can explore the concept of two-current modulation, fixed MA pattern on the left, two-current modulation on the right, and you see how two-current modulation reduces or changes the dose in different parts of the patient accordingly. We are in the process of doing also PET simulations and PET CT simulation, and to see how better fusion of the two modalities can improve localization of lesions in PET CT imaging. These are the kind of things that we can do in the visual domain with exact precision, because we know exactly, precisely where the tumor is, because we put it there. In the context of real trial, even though it's much more convincing, you never know the ground truth. So there are pros and cons on one versus the other. So there are things that we can do in virtual domain in the in silico models that you cannot do otherwise. So you can also get a tumor, image it different times, and see how radiomics characterization of that tumor changes depending on the protocol that you deploy. So in this complicated chart that I'm showing you, each row is a different protocol that is invoked as a function of dose or slice thickness and so on. And I'm showing you the relative bias on the color scale for different radiomics that we can extract from that tumor. So we can figure out what protocol can best quantitate the inherent attributes of the tumor, knowing what those inherent attributes are. In real clinical scenarios, you never know what the actual radiomics features are in truth, because you never have access to the tumor itself. Here we do, because we created the tumor ourselves and planted into the patient. And the last example I would bring you here is addressing the fundamental limits of AI. So current AI methods remain fundamentally limited by a number of things. What are those? Availability of training data for most and rare diseases. For most diseases, we just don't have the data. And for rare diseases, we don't. We can generate large and varied and rare data sets in the virtual domain. Groundedness, due to lack of ground truth of the training data. How do you know that training data actually is fundamentally good? Well, we can create data with inherent ground truth embedded in it. Generalizability, due to limited diversity of the data. Well, we can create data with targeted diversity. How much diversity you would like to have? We can create it. Dimensionality, in incorporating data from multiple sources, not just one data source. We can create digital twins that include data from multiple sources. Reliability, due to the lack of validation standards. We can essentially create validated and benchmark data for that. Explainability, to ensure relatability of the AI decisions. We can provide that by means of exploring ways to explain AI, because we know the ground truth and processes. Of course, there are other attributes of AI that are limitations, such as accountability to ensure consequence of potential errors, accessibility to ensure practical use in clinical settings, trustfulness, so AI can be trusted by physicians and patients. And we also, in the virtual domain, we don't directly address those, but we can provide means to make sense of AI, providing prototyping of innovation, and providing basis for digital twinning of persons and systems. So the question is, you might ask yourself, is that, so what is the prospect ahead for this technology? The idea is that we actually had a roundtable at Duke University last year to form and foster that. We decided to have a moonshot definition of what is the moonshot for this technology. And that was forming and fostering digital twins of every person, you and I, integrated into our patient charts, owned by us, belongs to us because it's our data, continuously updated with added data. Every time we go to the doctor, that twin of ours gets updated. Is used to deliver optimized care for the individual. When I need something, they can try it on my digital twin first before they actually try it on me. And used, if I give permission, for technology assessment, for real world evidence, and for population aggregate analysis clinical trials. That's where the direction they're going. There was actually, as I mentioned, this came about the Virtual Imaging Trials Summit that took place last year at Duke University in April. And I'm happy to tell you that the next one is scheduled actually starting on Monday. This coming Monday, the VITM 2025 is taking place in Manchester, UK, if any of you would like to make a visit there. Okay, I got a deep dive into research and development. On the other areas, I don't have as much time. I have 10 more minutes left. I'm going to try to do quiz fast. I'm going to give you some examples in other areas as well. I will wrap up. So, the foundational discipline is research and development about eventual contribution of physics. On top of that sits the clinical service, not independent of it, but relying on it. Immediate contribution of physics to patient care. So in the research domain, I said our physicists integrate the content to create innovative technology and applications. And in that space, we are in the business of creating technology for practice, right? So when we get this innovative technology and application, we get ourselves confused. Is that how can we apply that innovative technology and application most robustly and perfectly to the patient? How do you apply it to the patient? Then you need to have a clinical physicist there who works with other allied professionals to apply those diverse technologies and applications to the patient. So on the left side, we are in the business of creating technology for practice. On the clinical side, we are in the business of translating that technology to practice. So what are the frontiers in that space? Implementation science, translating this new application and technology into clinical practice. So if somebody drops you a new mammography machine, a new therapeutic regimen, a new ultrasound system, and say, use it, how do you use it? What is the best implementation strategy? Holistic quality control, adapting in vivo and in silico metrologies, extension from the in vitro methods that I mentioned earlier, phantom stuff, to actual clinical practice for higher relevance to patient outcome. I'm going to say a few words. And then consistent physics in direct line of patient care, making clinical physics essential in direct line of care. As physicists, we are uniquely qualified to understand and position the diversity of technologies that I showed towards consistent clinical output. The fact is that for most applications, patient comes in, go to physician, to radiologist and radiation oncologist, and eventually care is provided. Where is the physicist is sort of on the sideline. In the new model, physicist needs to be within the line of the care because we have unique expertise to contribute to that. So why do we need to do that? Because the confluence of three movements: increased diversification of technology driven by innovation, increased focus on precision and standardization of care, and the fact that other healthcare professionals are focused on horizons of their own. The technology is becoming diverse. Somebody needs to figure that out, and other physicians are busy. So we are the people who know that space well. We cannot claim or assume to be essential without taking on the responsibility. We are meant to apply physics to medicine, and owning and addressing the disparity of clinical practice, clinical physics across practices. The fact that I practice physics differently than your facility, that's a problem. Because if I am doing more than you do, maybe I'm just wasting my time. Or if you're not doing what I am doing, maybe you're not doing what you're supposed to do. So we need to become essential. We need to provide the same level of service, at least some basic level of service across board everywhere. You can think about, we are in the business of ordaining appropriateness of image, not I say image quality, but really clinical quality by in vitro methods, by prospective performance optimization, by by prescriptions, prospective protocol definition for the patient care, by in vivo methods, to actually look at the outcome. In the context of imaging, let me show you an example. Let's look at in vitro methods noise measurements. This is CT exam again. I'm showing you patient diameter on the x-axis, noise on the y-axis. The green line is measurement of noise on 2 scanners. You can think about, oh, I know how the noise changes the function of diameter. Do you? No. You only know that for a patient, for a phantom. If you do that in patients, you might get a different image. You see there are outliers here. So the question you should ask yourselves, if you got the green line, would that give you assurance of what happens in the actual patients? To some extent, but not fully, because there is more happening to the patient. And which noise actually matters, in the phantom or in the patient? Of course, in the patient, because we are about patient care. There are methods to make these in vivo measurements, and I don't have time to talk to you about this, but there are papers you can check out, and we have done a significant amount of work how we can measure things actually in practice. And we have demonstrated that the results matches the actual clinical performance. I'm going to go fast a little bit. The third element quickly I want to talk about is the education. How do we advance the educational enterprise that sits upon clinical practice and research and development? Again, we have the diagram on the left. In this space, we are now in the educational space. We are empowering experts for practice. That would be our students, our postdocs, our mentees, our trainees. And what is the frontiers in that space? Increasing the scope of required competencies, clinical skills, disease signatures, clinical nuances, hard skills of data science, process engineering, and soft skills of communication, emotional intelligence, and management. Balancing rigor and relevance, that duality that I mentioned earlier, how to balance those two sides of our psyche, if you will, toward mindful practice of medicine. Advancing methods and methodologies, integrating complementary advantage of principle and data-informed methods that I mentioned earlier, and also deploying NAMs, deploying, targeting, and monitoring relevant surrogates methodology of quality and safety in vitro, in vivo, and in silico. Last component, communal ownership, who we are together. The first one was who you are personally, what the discipline needs to be, I talked about. And the last one I want to briefly touch upon in the next 2-3 minutes is that who we are or ought to be communally. You can think about here we do that eventual, immediate, and delegated contribution of physics together. Culture of our practice matters. We have unity across diversity. Collegiality, camaraderie, mutual respect, and support needs to be supported in that space. You see, we come from different mindset, different expertise, different heritage, different practices in clinical, in academy, in industry, in the different countries, and so on, different professional organization, and we come with different backgrounds. Some of us have master's degrees, some of them have bachelor's degree, some have doctorates, therapy, imaging, non-radiation, and so on. We are diverse, but we work, even though we work individually, medical physics is formed and reformed and enabled through community. So what is the frontier in that space? We need to practice our humanity. Each of us matters. No one should devalue the agency and dignity of another. And there is a concept of cooperative medicine, engaging patients' voice and agency in their care. I'll say a little bit more in a few seconds. Practicing pragmatism, our collective calling matters. Medical physics is a co-creation of many, and excellence really needs the diverse perspective of all of us. We need to practice joy, seeking personal and professional flourishing. That would bring me to work every morning. And taking ownership of being a community, seeking unity across that diversity, and taking responsibility that we need to uphold a collegial space of welcome, safety, and kindness. So honoring patient agency, quality care is a shared responsibility of providers' expertise and patients' agency. Patients are not the subject of our care, they are the recipient of it. if they choose to do so. So patients have full agency in their care. So medicine needs to shift from elitism and paternalism to collaborative medicine. So we can think about ourselves, we're not machines, we are humans caring for humans. And this is a new area of new human way of practicing medicine, which has a significant implication in the way we do medical physics as well. So we can do all of these things, our education, our clinical service, our research and development and culture, so we can advance human health. So, take-home points. Thank you so much for sticking with me all these 50 minutes. Medicine still needs physics. Yes, it does. Because growing needs in medicine require scientific mindsets of physicists as scientists and healthcare professionals to design, to ensure, to enhance quality, safety, and consistency of patient-centered care. Patient-centered care, not machine-centered care. So medical physics needs intentional development, advancement of physics through existential personal commitment of physicists. That's personal commitment. Extending the reach and the scope of the discipline. That's research. Fostering the creation of technology and application for patient-centered care. Patient-centered care. These are out of order, sorry about this. Energizing and empowering effectual new contributors into the discipline. That's the educational piece. Clinical piece, owning the translation of technology into practice. That's clinical. Owning it, not just practicing in it. I use those words very intentionally. And cultivating a community for personal and professional flourishing. And I think those things go hand in hand. If you are professionally flourished, you're also personally flourished, and vice versa. And honoring the public agency and patient agency, putting our science in closer service to the society. Ultimately, we are here not to serve ourselves, but to serve our community, our patients, and public at large. So you can think about the progression of the medical physics is going from care for machines to care for patients to care with patients. And I have written some of this material in publication form, and you can find them, I'm sure, online. So I thank you for your attention, and I'll be happy to entertain any questions that you might have.
Thank you very much, Samei. It's fantastic and surprising lecture. Thank you very much. We have some questions. The first one is, how will AI affect the medical physics in the future?
I think there is a lot of excitement about AI for obvious reasons. AI is a new methodological tool at our disposal. And I use those words also very intentionally, at our disposal. AI is not our master. We are AI's master. At least for now it is. I hope that will remain that way. If so, then if we have artificial intelligence, I would also say there is such a thing as artificial stupidity. So we need to distinguish between which one is which. Like, not all intelligence are good. So I think I have seen a lot of naivety in the way we have approached AI. I think we should assume AI is a tool at our disposal, and intentionally and wholeheartedly engage with it, use it, and figure out how best to use it as a tool and add it to our arsenal of the tools that we bring to advanced patient care. Be nuanced, be careful, be excited as well, but not let that excitement run wild. And that's the way I would put it.
I agree. Well, another one is, how do you evaluate your models? And what parameters do you use to evaluate on how good the models are close to reality? Well, I don't know if you can answer this in a few minutes.
Very briefly, I would say we validate at every element. So no model is as George Box says, no model is perfect, but some are useful. So we don't need to have perfect model. In fact, clinical trials as a way of experimentation is not perfect either. In fact, nothing on this side of heaven is perfect. So it needs to be perfect enough or it needs to be close enough. So what we do is that validate the technology in the context in which we are going to use. For example, if you're trying to evaluate some sort of motion management plan, then I validate how my motion realistically reflect the motions in the patient with tagged MR. Then if I have done that, then I trust my motion models to be reasonably representative of what happens in the patient. The same thing with tumors. I do not claim validation or validity beyond the domain in which the validation has taken place. So you can do in small steps, validate for a given context, and for that context, for the claim that you're making, then you have a good enough methodology. I hope that in the same way that we apply phantom, for example, physical phantom. How good is your phantom? Provide the size of the phantom matches the size of the patient, we can say, well,
Yeah.
it's a reasonable phantom. Reasonableness is good enough.
Okay. And medical physicists will need to be more digitally skilled in the future and less practically minded.
Can you say it one more time?
Oh, if medical physicists will need to be more digitally skilled and in the future and less practically minded.
I think we need to have both. I mean, what medical physicists are, and I hope I emphasize this, we are very hands-on. We are, in fact, one of the attributes of medical physics is that we care about how care is practiced in the clinic, right? So we are not sitting in our offices and dream. We actually in the clinic and see how our technologies are being implemented. In that process, digital technology is one way to make sure that practical value is maximized and optimized in the most efficient fashion. Essentially, digital technology, being AI or digital twins or virtual imaging trials, are stepping stones to actual optimization of care for the individual, real human patient with physical body, right?
Okay.
In
Yeah.
other words, digital stuff are cool to the extent that they still apply to real world. I hope I got the spirit of the
Yes.
question right.
Well, we have, unfortunately, we have to finish, but if you could answer me, do you think that the universities, the professors are really prepared for this medical physics 3.0 to prepare the medical physicists? Because you presented all the skills and a holistic way that I love it. But I'm thinking if the university I prepare to give the adequate information for the medical physicist.
Um, I think if there is a will, there is a way. I think we don't need a revolution. We need an evolution. I think we need to take small steps. And depending on the context in which we practice, there are things that you can do that I cannot do toward 3.0 in your facility and vice versa. So I think we should be realistic. I mean, we are very pragmatic individuals, medical physicists are. We adapt. In the same way, get the mindset of 3.0. Really ask yourself the question, this phantom thing that I'm going to do, is that actually, how can I extrapolate from what I learned from a phantom to the actual patient? Try to explore that space as much as we can. We can't be very myopic just focusing on our machines. I guess the 3.0 is to really ask the question, am I touching patient care? And I think there are small steps in which we can. And many of us actually do. We are almost, many of us, halfway between 1.0 and 3.0.
Okay, well, it was an amazing presentation. You have more than 900 participants, and everybody love it. I see the message here, and thank you very much. I hope to see you soon in another webinar here. And I think that everybody opened a little bit more the mind. So thank you very much.
Great. Thank you for the opportunity. Thank you for honoring, for being present, for all of you who actually attended.
And thank you for the participants. Thank you very much, Stephanie, for joining us here today. Thank you all.
Thank you.
Bye.
Bye-bye.
Thank you, Simone. Have a wonderful day, everyone.